Well, hi everyone. I'm Janet Church, CEO of the Sjögren's Foundation, and with me today is Dr. Cassandra Calabrese. Dr. Calabrese is a rheumatologist and immunologist and has been the expert that the foundation relies on to keep us informed about COVID-19 and vaccines. So today we are going to address the new second booster recommendation that was announced last week on March 29th. So first, let's just say hi to Dr. Calabrese. Welcome, Dr. Calabrese.
Hi, thank you so much for having me.
Oh, thank you so much for joining us. We know how busy you are, and we certainly appreciate all the time that you give us to keep our Sjögren's patients informed.
My
So
pleasure.
let's just jump into this booster. So last week, March 29th, we learned about the second booster of the COVID vaccine was announced, and we've heard, for people over 50. Can you share a little bit about what the current CDC recommendation is, and kind of how it breaks down if you're over 50, under 50?
Yeah, I think that's a good place to start, just to start with what is the recommendation currently. And, I'll preface this by saying there are still unanswered questions and there's no, gold standard recommendation that's appropriate for everyone. And these are my insights and thoughts, and I hope that they're helpful. But I think it's an important thing to talk about what we're talking about here, because the recommendations have changed so frequently and they're really hard to keep up with. So as it stands, as you said, just last week, today's April 6th, last week the FDA and CDC updated recommendations such that for those who got an mRNA series of vaccines, a booster for certain immunocompromised persons and people 50 and older who received their initial booster or third vaccine dose are eligible for a fourth dose if it's been 4 months or longer since their third dose. So we're talking about two different groups: immunocompetent or healthy, not immunocompromised persons, 50 and older, and then people younger than 50 who have certain immunocompromising conditions, which range from being on immunosuppression for an autoimmune rheumatic disease like Sjögren's, having cancer on chemotherapy, being solid organ transplant patient, and a variety of other things. For patients who got J&J vaccine, they also made a recommendation that if you received a primary J&J vaccine, some of these patients then went on to get a booster dose with an mRNA vaccine, and those patients are also recommended to get a fourth vaccine dose. And the timing is 4 months since your third mRNA vaccine. And this is another source of confusion because it's over the past several months actually changed from 6 months to 3 months to 5 months, and now it's 4 months. Clear as mud.
Well, it is confusing, and it's hard to keep the little details like the 4 month versus a 6 month straight, which is why we wanted to have this conversation today. So, I'm really interested in this difference between Pfizer and Moderna, and we have heard a lot about J&J, and you just covered that for people that got the J&J to get an mRNA shot. Is there, if you started with Pfizer and all your shots have been Pfizer or Moderna, and you choose to get the second booster, should you stick with the same
That's a
medication?
good question. What we've learned so far is that it probably doesn't matter, this mixing and matching, if you got your first two Pfizer and your third and fourth Moderna, or whichever way you want to mix and match it. It probably does not matter at all. So if you had your initial 3 shots with Pfizer and where you go to get your fourth shot only has Moderna, that's okay. We don't think there's any negative impact from doing that. On the flip side, probably no benefit to doing that if you're wondering if you should seek out the alternate mRNA vaccine. Either is just fine. Over time, I should mention that if the recommendations are such that mRNA vaccines are preferred over Johnson and Johnson. Kind of a moot point. There aren't a whole lot of people starting their, you know, vaccine journey, but if you are, it's never too late. Pfizer or Moderna is recommended over Johnson and Johnson.
Okay, great. Well, thank you for that clarification. It is sometimes hard to understand what, why would you mix them? So it's very, very helpful to understand that. You just said, as we've learned so far, and I want to touch on that. Can you talk about what research has been done on vaccines, what we know about it, and especially if you know of any research with vaccines in autoimmune disease patients or specifically Sjögren's patients?
Absolutely. I can hit on a couple highlights. Probably the most interesting findings of late in the COVID vaccine world are immunity or protection against COVID after vaccine versus after an infection versus after both. And this is really important. What we know is the probably most protective protection against COVID is something called hybrid immunity, which means you were fully vaccinated and also had COVID. So many people now, of course, have had COVID. So this is provides your immune system excellent protection against getting COVID again, at least in the near future. Of course, being fully vaccinated, 3 vaccines, even with the new variants and Omicron subvariant, these vaccines still hold up very well against hospitalization and death from COVID. And that's very important to know. Where it comes into play in our current discussion about who should get a 4th dose, if you've been fully vaccinated with 3 vaccines and you had COVID recently, you probably do not need to run out and get a 4th dose. You have very good protection, probably for 6 months after your infection. And that's important to know. Other really valuable information that has been learned through studies on vaccine responses, so your immune system's response to COVID vaccine in patients who are immunocompromised, including Sjögren's patients. We've learned about the impact of various medications. We have learned that just having Sjögren's alone or rheumatoid arthritis does not increase your risk of getting COVID, and does not increase your risk of getting severe COVID, like your outcomes if you get COVID. But what does matter more is what medicine you're on, or even more important, comorbidities, older age, having chronic lung disease, chronic kidney disease. These things are what portend a poor outcome if you get sick. Drugs that we use and that you might be on that we've learned are associated with getting very sick with COVID. What stands out is rituximab. We've learned a lot about this. Patients who are on rituximab have kind of a 1-2 punch in that just being on rituximab, it knocks down your B cells. Your B cells are what make antibodies. Your B cells are what make antibodies after a vaccine and what make antibodies to fight an infection like COVID. And you don't have those. And that's associated with getting very sick and being hospitalized. So not being able to fight the infection and also not being able to mount a response to the vaccine to help you fight an infection. So this is very important. Just mention briefly, I know we're not talking about prevention, but there's a pre-exposure prophylaxis monoclonal antibody called Evusheld. It's a subcutaneous injection that's under emergency use authorization for patients like rituximab patients and other high-risk patients. And this is an injection you get to prevent COVID and is worthy of talking to your doctor about. But rituximab is the big one. Mycophenolate also reduces vaccine response. Methotrexate does as well, although nowhere near the degree that rituximab does. So the risk and vaccine response is still very drug dependent and not by disease like Sjögren's itself.
Interesting. Boy, that was a lot of information and some new information for me too. So to simplify it for all of our viewers, let's break it down by each kind of category and what you recommend this category should do. you were just talking about earlier. You said, so if someone, and I'm going to assume people watching this are Sjögren's patients, let's say that someone has been vaccinated and they have had COVID. Your statement was that they're probably okay for at least 6 months after the time they had COVID. So perhaps this booster at this time is not necessary. Do I have that correct?
Yeah, absolutely. And it is really confusing. And I hope to not confuse those further. The main source of confusion is the kind of paucity of data showing how much a fourth vaccine is helping. It's certainly not that it's going to hurt, but the question is who's going to get the most benefit. And it's, not a healthy 50-year-old. It's probably not an otherwise healthy Sjögren's patient who's on Plaquenil monotherapy. If you're, 60 plus or have other comorbidities, which really drive your risk for COVID and getting sick with COVID, such as age, 60 or older, having other diseases like chronic lung disease, chronic kidney disease, cancer, if you're a transplant patient, diabetes, really a long list of things. These are things that portend a worse outcome. And these are people who should think about getting a fourth vaccine. So
Okay.
age is probably the biggest one. And then level of immunocompromise from drugs that you're on. And when we think about drugs that Sjögren's patients commonly receive, there are, a range of drugs, with Plaquenil really not suppressing your immune system or placing you at increased risk for getting COVID or getting sick from COVID at all, nor does it reduce the effectiveness of your vaccine. So we really don't think of that as a risk factor. Drugs at the higher risk, on top of the list, rituximab number one, followed by mycophenolate and then methotrexate, but much less so.
So rituximab, you talked about, our rituximab patients know that they have not done well with vaccines. They've, I'm sure, all been working closely with their physician. And can you say again, so this booster is probably not something they're taking a look at, but say again, the medication that you want.
Yeah. We fortunately have a lot of new tools in our toolbox to manage outpatients who are high risk for severe COVID. And one of the most exciting is something called Evusheld, or tixagevimab, silgevimab is the generic name. It's a subcutaneous injection of a monoclonal antibody similar to, I'm sure many of our patients have had COVID and were referred by their doctor to get outpatient monoclonal antibody like RegenCov, or the many different iterations. So this is to prevent COVID. You get it before you get sick, gives you the antibodies that your immune system can't make after the vaccine to protect you over many months from COVID. It's subcutaneous injections in the gluteal muscle. That's under emergency use authorization since December, indicated for high-risk patients like rituximab patients. So if you're on rituximab, you should talk to your doctor about pre-exposure prophylaxis monoclonals.
That's great. It's so exciting that there's multiple options there and things that patients with rituximab can do that are taking rituximab. Now let's talk about, I want to talk about, you did mention methotrexate. You didn't mention leflunomide. Can you talk about leflunomide and methotrexate and where that patient falls? Because we have a lot of patients in that group.
Exactly. What really stands out, like, I don't want to sound like a broken record, is rituximab. Rituximab treated patients are on another level. There are a lot of data that show that methotrexate reduces vaccine effectiveness. However, is not significantly associated with worse outcomes from COVID, meaning there's probably a greater chance of you getting COVID, or what we call breakthrough COVID, getting COVID after you were vaccinated if you're on methotrexate. There are not a lot of data or experience to suggest that will be a worse COVID than someone who's not on methotrexate. but still important to be aware that it can reduce the vaccine effectiveness, therefore increasing your chance of getting COVID, even though you've been vaccinated. So a good example of someone who should pursue a fourth vaccine.
So that would be, and that would that be the
And
same
the same
for
would stand for
leflunomide?
leflunomide. Yeah, leflunomide, that's important to mention as well. In the grand scheme of things in the rheumatology world, a lot more patients are on methotrexate than they are on leflunomide, so we don't have as much experience and data, but it would be very similar to someone on
Okay,
methotrexate.
excellent.
Yeah, I would
Oh,
lump them the
this
same.
is so like you said, clear as mud when we first started talking
Yeah.
today. But it is
Yeah.
confusing, but it's so important to try to break it down. And I think we've done a good job at talking about the vaccines. Um, I wanted to touch base on this new BA.2 variant that we hear is coming over from Europe. Can you talk a little bit about that and our risk?
Yeah. BA.2 is what's called a subvariant of Omicron. So Omicron, which was the cause of the last surge of highly mutated SARS-CoV-2 virus, the virus that causes COVID, and now it has mutated further into Omicron subvariant called BA.2. And fortunately, while it is very contagious, probably more contagious than Omicron, it does not seem to be more severe. And protection through vaccines and benefit of all the medications we use, both outpatient and inpatient, still seem to hold up pretty well against Omicron. So other parts of the world are seeing little surges from BA.2. We are not really seeing the effects of that quite yet. We wonder if we will, and if we do, how bad they'll be. Certainly not as bad as our last surge, but the best news is it is not more severe than previous variants.
Okay, that's good to hear. So we still don't want to get it, but at least
Correct.
if we do get it, we especially if boosted, will be
Exactly.
better. We won't be in great harm's way necessarily. So I think my last question for you is we've been doing this so long, and I know for so many people, keeping up with the masking and the hand sanitizing, et cetera, seems to be waning quite a lot, and even state by state, regulations really loosening up there. What do you recommend for Sjögren's patients moving forward?
Yeah, comes up a lot these days. What should we still be doing? What do we need to not do anymore? I think just across the board, there's, common sense things that should have always been done and we should continue to do, like hand sanitizing before you eat. This is, all the hand sanitizer. This is not like a novel concept, and it's not to, lather your hands every 5 seconds with hand sanitizer. The concept with COVID and everything else is to wash your hands before you're going to touch your face, your eyes, or eat. And that should always be the case, no matter what you're doing, whenever you're doing it. That's the goal there, to not get germs you may have gotten from touching something or someone on your mucosal membranes and get sick with COVID, with the flu, with the GI bug, with anything. So keep doing that. The masks is another one, depending on your level of risk, which may involve a helpful discussion with your doctor, depending on your specific disease and drugs, with rituximab patients, again, kind of being an outlier. We can have some more comfort in going out and about, going out to dinner, being with friends, surrounding yourself with smart vaccinated people. I envision myself always wearing a mask while I'm traveling now on an airplane and in a busy airport. I think that's just smart. I still wear my mask in the grocery store and probably will for a while. And I encourage my patients to do the same too. But I do think there can be more comfort in, doing activities, being out and about, and just being aware when you're in crowds. And I would wear my mask when you're, in a crowded area.
Absolutely. I'm following the exact same system, so to speak, that you are. That was it for the questions that I thought our patients would really want to hear about today. Did I leave anything out that you want to share?
No, I think that the main message, because this is so confusing, is that, or kind of in summary, most immunocompromised persons should get a fourth dose. In what we call immunocompetent persons, or someone, who's not on an immunosuppressing medicine, the decision should be driven by risk benefit ratio. And, there are very few risks to COVID vaccines, but there are people that have unexpected side effects that, should be taken into account if there is consideration for a fourth dose and uncertain how much they'll benefit from that, like a younger, more healthy person. And these are very, very rare side effects that we do see, with a good example being people who get tinnitus or ear ringing after COVID vaccines. This is well reported, still infinitesimally rare, but that affects quality of life, affects hearing, and if some patient experience that and they're not at very high risk or in the risk bracket to benefit from a fourth vaccine, I think it's very worthwhile to consider holding off on that fourth vaccine for now. But if you tolerated your third dose, go for it. And overall, very favorable risk benefit ratio. The older the age, the higher priority for fourth vaccine should be across the board, whether you're on immunosuppressing medicines or not. But the space is ever evolving, and this is where we stand now.
Well, and since it's ever evolving, that I'll be coming to you in the future to keep you surprised.
I
And
hope I've provided helpful information, and happy to help with any further clarification down the road, because it is confusing, and I think it's helpful to have discussions like this.
absolutely. And we are so grateful that you've made yourself available to keep us well informed. I want to thank you so much for being with me today and to just review as best we can the knowledge that you have and help me disseminate it out to our patients. So thank you so much, and I hope you have a fantastic day.
My pleasure. Thank you for having me.
You bet.